Welcome to part 2 of The Heart and the Kidney, New Game Players in Type 2 Diabetes webinar recording. This webinar was recorded on the 28th of May 2021.
Hello, I'm Chantal Mathieu. I'm Professor of Medicine at the University of Leuven in Belgium and Chair of Endocrinology at the University Hospital Gasthuisberg. I will talk today about cardiorenal risk in type 2 diabetes, and I will actually build on the patient who was presented by Dr Itzhak. Here are my disclosures. Type 2 diabetes is a complex disease where we have actually the combination of this big cardiovascular risk because of insulin resistance, the hyperinflammation, etc. But we also have in every patient a certain degree of beta cell failure. And this beta cell failure contributes to the hyperglycemic component in people with type 2 diabetes. And so it is really this whole picture that we need to attack when we talk about treating people with type 2 diabetes. Now, coming back to Donna, the patient of Dr. Itzhak, what is clear is that her hemoglobin A1C at 7.6% is not well controlled under her present treatment with metformin and sitagliptin. Also, her blood pressure is quite well controlled at 130/80 millimeters mercury with an ACE inhibitor. Now, what I really appreciated in the approach of Dr. Itzhak is that he talked to the patient and that he put her at the center of the treatment and also allowed her to voice what she wanted to happen in her treatment. And so the attention to be given to lifestyle, for instance, to exercise, to losing weight is very important and should never be underestimated. Another very important point is the multifactorial approach that we need to take in people with type 2 diabetes. Indeed, glycemic control is very important, and I alluded to the hemoglobin A1C that was not sufficiently controlled, but also lifestyle modifications, as I already said, the blood pressure control preferentially by using ACE inhibitors or ARBs, but also the treatment of the dysglycemia. And here the LDL cholesterol is at 117 milligram per deciliter, which is not sufficiently controlled for an individual with type 2 diabetes. And also any individual with type 2 diabetes, especially a postmenopausal woman of 59 years of age, should have a statin on board, and that was also not the case here. So I was very happy to see that Dr. Itzhak added a statin, namely simvastatin, at 20 milligrams per deciliter, at 20 milligrams per day. Still, when you look at the LDL cholesterol level, this is not sufficiently controlled, and we will come back to that later on. Also, after 1 year, her hemoglobin A1C is now at 8.2%, which is not well controlled at all. And there is another clinical parameter that now came into the picture, namely shortness of breath and fatigue. And this is an important flag in people with type 2 diabetes because it can suggest heart failure. And heart failure has now come much to the forefront in the treatment of people with type 2 diabetes and also in the consensus statement, for instance, between the ADA and the EASD. Indeed, we said that if you have a person with type 2 diabetes presenting with heart failure, you should really always have an SGLT2 inhibitor on board. Now, in this consensus, a lot of attention was paid to GLP-1 receptor agonists and SGLT2 inhibitors. And that is because we now have solid evidence that these agents can really affect outcomes in people with type 2 diabetes beyond hemoglobin A1C control. Now, the two winners were indeed the GLP-1 receptor agonist and the SGLT2 inhibitors. But what about Donna? What about this patient with heart failure? What about the GLP-1 receptor agonist and hospitalization for heart failure? There, as shown here in this meta-analysis by Dr. Christensen, the results are not extremely convincing. There's only a very small reduction in the risk of hospitalization for heart failure by GLP-1 receptor agonists. And so in this patient, it would not be our preferred treatment to be added to metformin. The preferred treatment is an SGLT2 inhibitor. And here you can see a summary of all of the cardiovascular outcome trials that have been done with SGLT2 inhibitors or also with sotagliflozin, the combined SGLT2-SGLT1 inhibitor. And here you can see the dramatic effect of these SGLT2 inhibitors on the risk for hospitalization for heart failure, and hence the preferred choice for this patient. Now, two small remarks. Our patient was a woman, and looking back at the big cardiovascular outcome trials with SGLT2 inhibitors, only a minority were women. And so, as a woman, I'm really calling for more studies also showing the evidence in women. Another remark is the age. Indeed, these studies were done in people above 60 years of age as a mean, and our woman was only 60 years of age. So two small caveats when interpreting the results on these big cardiovascular outcome trials. But so let's look at Donna, and as Dr. Itzhak showed, he added, or he substituted actually the DPP-4 inhibitor by an SGLT2 inhibitor, dapagliflozin, where we have the DECLARE study to support the choice of this SGLT2 inhibitor, and that brought down the hemoglobin A1C to 7.2%, which is good, but still not perfect. Now, I want to bring you back to two other observations. So he changed the simvastatin for atorvastatin, a more potent statin. That is good, bringing down the LDL to 81 milligram per deciliter, but I would urge you to bring it even further, and thus bring the atorvastatin up to 40 and even 80 milligrams per day. Also, there was one additional phenomenon happening in Donna, namely she developed microalbuminuria now with an albumin over creatinine ratio of 283 milligrams per gram. And also looking at her blood pressure under the lisinopril of 20 milligrams per day, this is not enough, 142 over 88 millimeters mercury. So here something needs to happen. Yes, the dapagliflozin will be beneficial for the kidney, but also the ACE inhibitor should be increased in dose, and eventually a calcium entry blocker or a beta blocker should be added in this woman. So that is my opinion, very important. And again, let's not forget lifestyle advice to this lady. Now, what should be done for people with microalbuminuria above 200 or 250 milligrams per gram creatinine? Again, coming back to our consensus, again, the SGLT2 inhibitors are preferred. So the dapagliflozin was a very good choice in our patient. And here I show you the evidence, dramatic effects on renal-related composite outcomes for all of the SGLT2 inhibitors, and in particular, again, with dapagliflozin in the DECLARE study. This brings me to my conclusions. I agree with my colleagues in primary care that the management of hyperglycemia in people with type 2 diabetes has become very complex with all these glucose-lowering medications now available. Atherosclerotic cardiovascular disease, heart failure, and chronic kidney disease are important complications in type 2 diabetes, but we have now agents that can help in tackling these complications. Indeed, the GLP-1 receptor agonists and the SGLT2 inhibitors now are classes that occupy a very prominent role in our choices of anti-diabetic agents, because they have effects on diabetes outcomes way above hemoglobin A1C. And again, coming back to this patient, I think that SGLT2 inhibitors in particular have beneficial effects in people like our patient with heart failure and chronic kidney disease. Thank you for your attention.